On behalf of KPCC and LAist and our partners for the National Center for the Preservation of Democracy, thank you so much for joining us this evening. I am Elaine, a producer here at KPCC in person. We produce all kinds of events like this one tonight. Tonight's forum is the third installment of our SoCal Solutions series, in which we ask you to help determine the specific focus of the program by submitting your questions and suggestions. We then put it to a public vote. For tonight's forum, the top vote getter was focused on universal access to healthcare. Just a few things before we get started. We are live streaming, so please no audio or video recording. Feel free to take pictures. We just ask that you turn off your flash. If you could please silence your phone, that would be great. For those of you on social, we are using the hashtag Universal Health. After the forum, we hope that you guys stick around for a casual reception in the lobby. That about covers it. Without further ado, your host, healthcare reporter Michelle Faust Raghavan.
Hi, thanks for coming. My name is Michelle Faust Raghavan. I am a healthcare reporter at KPCC. I've been covering health and healthcare policy for a number of years now, and I'm very glad that everyone came out. So give yourselves a round of applause for coming. So we're here because the United States spends more money per capita on healthcare than any other industrialized nation, but we also have some of the worst health outcomes of any industrialized nation. So increasingly, Americans want this to change, and they want our government to help bring down costs by also, at the same time, improving quality and increasing access to healthcare. This week, the Kaiser Family Foundation had a poll of registered voters that found that healthcare is one of the main things that people want the presidential candidates to address in this 2020 election as people are getting ready for that. And that's especially true for Democratic voters. The same poll also showed that many voters misunderstand the many proposals before Congress that look to create a national health plan. The best of those that's known is the Bernie Sanders plan, the Medicare for All. So people want answers, right? So that poll also found that many people understand that Medicare for All would be one thing that would create a national health care program, but would also cost more in taxes. What they don't often understand is the way that those propose to potentially save money in the healthcare system. Meanwhile, people are struggling to afford their health care. A recent Gallup poll showed that at least a quarter of Americans chose to skip healthcare treatments because of their fear of the cost. That can't be a surprise at all in a country where medical bills are still the leading cause of bankruptcy, even with the gains in the health coverage that we've gotten under the Affordable Care Act. So it's no wonder that KPCC listeners, all of you, LAist readers, are most likely to ask me questions about healthcare costs and proposed reforms to the overall system. So the question we're addressing tonight is there a path forward with universal health care that would provide quality care and not break the bank? The question has been posed for many years. Governor Schwarzenegger vetoed 2 attempts to create a single-payer system in California in the 2000s. A bill in 2017 that sought to start a process was passed in the state Senate, but that was pulled before it got to the Assembly. That was not the end of the conversation in the state, however. The state legislature has taken some steps designed to lower the cost and increase access to care. Governor Newsom's budget will include more money to help lower the cost for middle and low-income families and help them buy health insurance on Covered California's marketplace. It also expands Medi-Cal eligibility to include people between the ages of 19 and 26, regardless of their immigration status. To kick things off, let's look at some of very, very simplified explanations of 3 models of universal health care from other countries around the world and how they have achieved it. So again, very, very simplified. If we look at first the Canadian model, upwards of 70% of healthcare is covered by the federal and provincial governments. Most healthcare providers are private, and they're paid on a fee-for-service basis, covering basic services. Some people have additional private insurance to cover the cost of other things that are not covered by the government. The annual out-of-pocket cost per person is less than 2/3 of what we pay here in the United States. The United Kingdom has socialized medicine, where the doctors work for the government, hospitals belong to the government, and care is mostly free at the point of service. Consumers pay higher taxes to cover the cost of the program, but still England spends just over $3,000 a person on health care. That's about 1/3 of what is spent in the United States. If we look at the model in Germany, everyone in Germany is required to have health insurance. Sound familiar? Insurance is a hybrid public-private industry. Most people buy insurance through highly regulated nonprofit sickness funds, and those are often funded by income taxes. The cost is based on income, and your employers will pay a portion of that. If you can't afford insurance, the government will cover most of those costs. Germans spend about half of what Americans spend on healthcare. So to discuss this, I want to now invite our panelists to come up. First, I'd like to invite Anthony Wright, the Executive Director of Health Access California. Dr. Elaine Batchlor, Chief Executive Officer of the Martin Luther King Jr. Community Hospital. Dr. Geoffrey Joyce, Director of Health Policy at the USC Schaeffer Center. And Angelica Ramirez, of the Executive Director of the California Physicians Alliance. So thank you all for being here. I'm glad to have this conversation. I want to start with basically, let's deal with the main question at hand. The whole point of this conversation is there a path to universal health care that will provide quality care and not break the bank? And we just went over a handful of models. Do any of those look like a model that we could possibly we could address that with? So let's go ahead and start with you, Anthony.
So the answer to the question, is there a path? The answer is yes. Every other country does it. Why shouldn't America? We need to get to a place where everybody has access to affordable health care. We need to get to a place where the healthcare costs are not breaking the bank of us, whether as workers and our paychecks, whether as employers and our bottom lines, whether as taxpayers, and in terms of what we're contributing in our healthcare system. As you said, we spend more on healthcare than anybody else in the entire world, and it's not because Americans use healthcare any more than anybody else. In fact, we actually use healthcare less. We have less incidents of going to the doctor, of going to the hospital. It's because that per unit price is just so much more in America than in other countries, and part of that is because we don't use the power of us as citizens, as the purchasing power, as all of us together to bargain for the best price and value. And so there are ways to do it. As you mentioned, there are different ways to do it. Each country does it. Each industrialized country that does have universal care does it in a different way. And frankly, many of us here in America do it. We have a British-type system for our veterans in the VA. We have a Canadian-style system for our seniors in Medicare. We just instituted for some who are in the individual market something close to a German-type model with the exchanges, but we also are unique in having huge cracks in that system. And so we need to take steps, and we have taken some steps with the Affordable Care Act, but there's many more to go.
Okay. Dr. Geoffrey Joyce.
As Anthony mentioned, I think there are many ways to get there. There's not one simple solution. I do think there are politics involved, as well as just what is the best way to cover the population. Clearly, I think if you go to a system like in Britain, there are flaws there. They have long queues. They have limits on, they make societal decisions that I think would be very unpalatable to some Americans. So from a political perspective, certain systems that work well in other countries may not be feasible or as I think, accepted here. The system in Germany, I think, is more akin to what some people have been talking about doing in the United States, of managed competition, but taking it out of sort of private hands fully and making it more regulated by government. In Germany, the government negotiates prices, which, as Anthony mentioned, is really the outlier in the United States. If you look at spending on healthcare, it's price times quantity. And our quantity generally, outside of prescription drugs and high-cost imaging, is in line with the rest of the world. It really is pricing. And so the question is, how would we price and do it in a way that again, there will be winners and losers no matter what we do and what type of reform we do, so we have to do it carefully.
Angelica.
I agree with the other panelists that there definitely is a path forward, but it hasn't been written down and thought through and distributed to the public. So even though there is a path forward, we have to come to an agreement, and it has to be written down so that there can be some sort of evaluation to make sure that we don't harm anyone that is currently reliant on the current healthcare system. And we also have to make sure that we continue moving. Like Anthony said, we had some great gains under the Affordable Care Act, but that doesn't mean that it's fixed and that we have universal healthcare. In terms of the different types of systems, I think that it's perfectly normal for Americans to want a uniquely American system. And I think that based on the needs of our country, that we can take pieces of each of these systems that work for us. It doesn't have to be one or the other. We can definitely go ahead and shape it to meet the needs of our residents.
Dr. Elaine Batchlor.
Yes, I agree with all of our other panelists that yes, there is a path forward and we should find that path. It's well past time for us to provide universal coverage in our country. Healthcare is a basic human need, just like clean air, clean water, education. We find a way to provide all of those for all of those human needs. We have the means to provide healthcare for everyone. We currently have a system that's not working well for many people. We have a 3-tiered insurance system in this country. We have commercial insurance for people who get insurance through their employers, but many of those people are struggling with affordability. We have Medicaid, or what we call Medi-Cal in California, for low-income individuals, but because Medicaid pays such very low rates to providers, low-income individuals struggle with access to the care they need. Medicare for the elderly seems to be the system that meets the needs of individuals the best, and thus I think a lot of the calls that we're hearing now to expand the number of people on Medicare to more, or if not all, Americans. So I commend the people that are here today, because I think we're all going to have to learn more about what those options are and what those potential paths are, and act from knowledge and not just from fear of the unknown.
Speaking of Medicare for All, I'd like to toss for a moment now to the Director of Healthcare for All Los Angeles, Maureen Cruz, who's also a nurse and is a supporter of Medicare for All.
Yes, I would say one of the things that America is unique in is that we have people dying in this country that wouldn't die if they lived in any of the other countries. We have 37,000 people who die every single year in this country because they don't have access to care, and many more die because of the inadequate access to care. And part of that is we don't really have a healthcare system. We have a medical industrial complex. We have a Wall Street-based system where our healthcare is a financial instrument, and we are the profit centers for that system. In order to provide a solution, you have to ask, what is the problem? And the problem is we have a system that's based on profit. And it's based, the insurance industry, the pharmaceutical industry, and the hospital association industries are practicing medicine without a license. We have so many people in this country who are not only rationing care themselves, and these are people with insurance. They can't afford to use their insurance because of the system that we have. We have a system where if it makes money for Wall Street to give you care, you get it. And if it makes money to deny you care, your care will be denied. So we have the number one cause of bankruptcy in this country is medical debt. You ask someone in Canada about medical debt, they don't know what you're talking about. It's unique to America that we have medical debt and that we have people dying because they can't not access care. So one of the first things we have to do when we look at a solution is say, well, what are the problems? Number one, we have to get rid of the insurance industry. We have to get rid of for-profit, siphoning money out of the system. It's very simple. If you want a medical system, a healthcare system that offers care to people, you cannot extract $1 trillion a year out of the system for for-profit entities. And that's what we have.
Okay. Thank you. Thank you. So a lot of the conversation that we're having so far is coming back to cost and people rationing themselves or people not getting access because of cost, whether or not they have insurance. And it kind of throws it back to a listener question that we received ahead of the event. Why is healthcare so expensive here? And why does it continue to increase so much every year? So I'd like to get started with that question. Geoffrey, Joyce, if you could please get started with that question.
We do much more than any other country, do have a for-profit in the pharmaceutical industry. We basically set prices, what the market's willing to bear, as opposed to government negotiated or fixed prices. We have for-profit insurers, we have for-profit hospitals, even though historically it's been a not-for-profit sector. I do think there's been sort of the capitalistic sort of historical legacy that we have a dynamic capitalistic type system. And when you mention rationing, I think it's important to recognize that we do ration, every country rations healthcare. Typically in Europe, it's done on the supply side. They restrict access to expensive therapies that they don't think are cost effective. They don't let 85-year-olds get heart replacements. They make societal decisions of what's cost effective and what is not. On the US side, we typically ration based on your ability to pay. So if you have generous insurance or you can afford it, you can get access to any technology. So I do think it's all countries ration. I think we make decisions, and it's both political and philosophical about, I think Americans feel they have a right to see any provider and have choice of providers and have access to treatments, where I think it's much more of if this is not socially cost effective, that's okay, we'll forego that in this country, where in the US, I don't think that's part of the nature. But it's getting to your broader issue about costs. We do not negotiate, typically. The government does not negotiate prices outside of Medicare and Medicaid, and that is one of the reasons why we spend significantly more than other countries. Having said that, it's not just the healthcare system. We can't say we don't do as well as Britain or we spend more simply because of our medical care system. It's also the health of our population, the diversity, and the sort of birth to grave type coverage, I think, that manifests itself in poor health outcomes.
I mean, it sounds like you're speaking towards the social determinants of health. And Dr. Elaine Batchlor, you and I have had conversations in the past about how that adds to the cost. When you've got people who are not getting good health care before they come to the hospital, they're not doing as well when they're there. Can you talk to me a little bit more about that?
Yes, so when we talk about the social determinants of health, we're talking about things like access to healthy food, access to safe places to exercise, transportation, employment, living in safe conditions, environmental toxins. All of those things contribute to health. And in other countries, like in European countries, they spend more as a society on those social determinants. Europeans spend twice as much on social aspects than they do on healthcare. In the United States, we spend about 90% as much on those social determinants as we do on healthcare. So we have a ways to go to address those social determinants. Fortunately, people are starting to realize that it's an important area that needs investment, and we're talking about it more and we're doing more. So for example, I'm a hospital, but we are experimenting with programs to provide healthy food for individuals who have conditions like diabetes or heart failure that require a healthy diet. We provide transportation for people who need help getting to health care. And even better, we're starting to take the health care to where people live and where they are comfortable receiving it. So I think we're starting to realize that that's an area that we need to invest more in so that we're not spending all of our resources on health care.
Thank you. I'd like to turn now to Louise McCarthy. She's the president and CEO of the Community Clinic Association of LA County. A lot of your patients are in the same situation where they don't necessarily have access to all of the social determinants of health, but your mission is to try to provide more health care before they end up in the hospital.
Absolutely. I would say that, and I really appreciate Dr. Batchlor's comments about the social determinants, that patients are coming into clinics, hospitals, et cetera. It's housing, and housing affordability is a real chief concern here in Los Angeles, especially as we're looking at a $15 minimum wage, and the fact that some of the minimum wage increases will actually end up making people ineligible for Medi-Cal in California. So this challenge, this push-pull of trying to create income equality at the same time as just the cost of living in California, in particular Los Angeles, is so high, such that now as the federal government is looking at change CPI and rebasing how we handle our federal poverty level, which would disadvantage us even more than it does today, the fact that if you make X amount in California and X amount in Alabama, you're at the same place on the federal poverty level is a real challenge when it comes to accessing federal programs. So health centers, I think when we look at the question of the social determinants and where cost happens, primary care is not the cost driver in healthcare. Upstream solutions are not the cost driver in healthcare, but the problem is that we put the long in longitudinal. You will not realize our savings this year or next, but you will realize them in the out years when those hospital visits don't happen. And that's the struggle with reorganizing the system, is to say, how do we reorganize it and recognize out year savings as opposed to current year spending?
Well, it's interesting that you mentioned housing. You may have noticed if you came in, they had the panel with I'm soliciting questions. I'm taking a new focus looking at the health of older aging adults. Most of the questions that I've gotten in the few weeks that we've had opened that up with the mission statements at KPCC have been specifically about housing and older adults who are not getting that kind of a care. So it goes back to the questions that I'm getting, what you mentioned right there. So I wanted to kind of turn it to you, Angelica. You can talk about a little bit about what can physicians do. I had a conversation really recently with a physician, and he said, you know, the goal is, as I mentioned in my intro, improving access, improving cost, improving the quality of care. But the physician with whom I spoke said, you really can only have 2 of those 3 in a medical system. And I wonder if you agree with that.
No. No, I don't agree with that. I think it's unfortunate that that someone would have the thought that you have to pick and choose. I mean, we at CAPA believe that everyone should have access to high quality, affordable, accessible, sustainable healthcare. And I think that it's really limiting to think that we have to choose what we want and give up what we want really to have as an outcome. I think that it's really important to keep pushing for the changes that need to happen. I myself come from an underserved community, so this is deeply personal for me. And I was raised on Medi-Cal, and I know that to individuals that are reliant on these health services, that it matters whether or not someone is out there with them asking for these changes. And I don't think that we can only have 2 out of the 3 in a healthcare system. Why do the other countries have a system that meets all of the qualities that we want to see in our healthcare system? So I think that that's just a way to deflect and not want to work on this. Really, it will take a lot of work to get to universal healthcare, and I think that we really can do it. So I would disagree with that statement.
Anthony, I would like to turn that question to you.
I mean, I think, I agree with Angelica. I think the issue is we have specific issues in our healthcare system with regard to costs. I mean, I think it's absolutely true that we underinvest on the human services side, and that balloons out into our health care system. And I think that there is some evidence that some of the differential between us and other countries is because of that. That because we don't invest in housing and childcare and education and other things, then that gets reflected in healthcare system. I think there's another issue, which is just about the complexity and the confusing nature of our healthcare system. With all these different middlemen and problems and procedures that are in place that we could do a lot to streamline. That's one of the reasons why my organization for 30 years has supported the Medicare for All solution and has worked year in, year out to try to figure out how to standardize and create clear standards and consumer protections for folks dealing with the healthcare system. But fundamentally, it comes down to this question of price. And there are trade-offs in any reform you do, but some of those, those are trade-offs between different parts of the industry, not necessarily for the patient, which at the end of the day is not just another stakeholder, it's the point of the healthcare system. So in other words, if there is a question about how do you negotiate for what is the rate that we pay for certain providers, then there is a question about what is fair, how much is too much, how much is too little. Maybe maybe Medi-Cal or even Medicare pays too little in some situations, but should other providers get paid 3, 4, 5 times the Medicare rate, which happens now if they have a certain market power? And that's actually fundamentally one of the issues that we want to resolve, is that at the end of the day, how much people get paid for healthcare actually has little relationship, if at anything, with the cost of that care, the quality of that care, the outcomes of that care. It actually has much more to do with what is the relative market power of any one part of the healthcare system versus the rest of it. And that's not an incentive for improved quality or equity or reduced cost. That's just an incentive for a hospital system to get bigger, for a certain group of specialists to have a bigger a payment schedule. And we need some sort of rationality to our healthcare system. And I think that there is a role for government to impose that. If we're going to rely on even market forces where the market does exist in healthcare, which is not a lot, we need to set the terms so that they actually encourage the innovation we want, rather than the innovation that is just about greater consolidation and greater consumer confusion.
Dr. Elaine Batchlor, reimbursement rates are very important for a hospital to be able to work. So I wonder what your thoughts are on that.
Well, I had a couple of thoughts. One is the complexity that Anthony is talking about is part of the cost problem, because a lot of that complexity is what other people would call administrative waste and adds to the cost. In addition, we have a system where the payment side is very fragmented with a lot of different insurance companies and health plans, and they really struggle to achieve that market power to be able to demand lower prices and lower rates from providers. So I think both of those things are problematic. Now, I work in a low-income community, an underserved community, and our biggest issue is equity. We're on the low end of the reimbursement scale, and because the reimbursements to providers in our community are so low, we don't have the physicians there, we don't have the prevention and disease management, and as a result, people come into the hospital with conditions that have gone way out of control, and we spend more money on the back end to treat people who are far gone than we would spend on the front end. So I think Louise was talking about the need to invest more in primary care, in disease management and prevention, and that is another way that we're going to get a handle on health costs. Right now, we're spending way too much on emergency care, on in-stage care, and not enough on the front end.
Okay. Dr. Joyce?
Just following up on that, I agree with Elaine in the sense if you look at differences between the U.S. and, let's say, European countries or Japan or Canada, we do spend proportionately less on basic primary care and much more on specialty care. I think there's a sense of I should be able to go and see an ophthalmologist, cardiologist, whatever specialist, and there was some backlash by consumers when managed care came in the 80s and 90s to say, you have a gatekeeper, a primary care doctor who's going to sort of monitor whether you have access to those specialists. So I think we do underinvest in basic primary care, which I think most other European countries do better, and we tend to spend too much in specialty care.
Okay. I'd like to take a couple of moments to take a question or two from the audience. So we have a couple of runners here that are here to take your questions. Does anyone have a burning question? You're gonna hold it. Okay.
So I'm curious, it's really interesting to think about the other countries and what we have, but so I'm a primary care physician, and I was lucky enough to go to public health school where I got a lesson on how we ended up where we are today. And then I also happened to be there when the Affordable Care Act was passing, and it was like this incredible, dramatic story of how is this gonna pass and how is it actually gonna happen? So just being pragmatic, like, you know, even if we wanted to be Germany or a mix of Germany, like how are we going to get there given the political reality? And in particular, given all that you've mentioned about negotiating costs, how do we, you know, that just seems like a no-brainer. Like, why are we not, is that the first step to say, like, you know, Medicare gets to negotiate drug costs?
Yeah.
Can
Go
I
ahead.
start?
Yeah.
Well, drug costs are a separate, complicated issue. Part of Medicare Part D, the drug program for seniors, in the legislation was that it would be an industry sort of competition among plans, and the government would not negotiate prices. So it would take an act of Congress to change that. Drugs are a somewhat separate issue. I think the broader issue you mentioned of how do we get there? And I think that's one of the more, I think, somewhat disingenuous parts of Bernie Sanders' proposal is, you know, we have about 160 million people who have private insurance today, and most of them are fairly happy with the quality of care that they have access to. Not that doesn't say that there are segments of the population that don't. Changing that system for 100, I mean, just look how Obama was just crucified for saying you're not going to lose access to you change your doctor. And some small fraction did have to under the ACA. So if you want to try and transform 160 million people with private insurance that are fairly well covered now and say we're going to put you in Medicare, and Medicare's got many quirks. It's a very unusual health policy. I don't think that's very realistic. So I think building on sort of a more towards moving towards managed competition, more managed care, which we've seen Medicare and Medicaid do increasingly over the past 20 years, where there are private firms that are paid something by the government, a fixed per month or per year fee, to manage that population, where they have incentives to provide more cost-effective care, provided you put some quality parameters around it so they don't shirk on care and don't provide inadequate care. I think that type of managed competition and moving towards that away from traditional fee-for-service Medicare is a place that's more pragmatic and realistic.
CAPA has a plan, a couple of ideas for that, so I'd like you to take that, Angelica.
Yes. So thank you for asking that question. Obviously, that is a question that anyone who supports universal health care, Medicare for all, or a single payer, that's what they're asking. Why aren't we doing this? It seems like a no-brainer. So CAPA actually believes that we need a strategic, approachable, and realistic way to get to universal health care and a unified system of public financing, specifically. And we actually came up with a document. We are calling it the Roadmap to Golden State Care that takes into account our current healthcare system here in California. And it lays out a plan that is strategic, approachable, and realistic. The beauty about our plan is that it is phased in. There are 3 phases so that we don't disrupt the care for anyone who is currently really reliant on our current healthcare system. And then also so that any positive changes any changes that we make, we want to ensure that they are positive, because sometimes you think that you are going to change a small piece of the system and it has negative consequences. So we want to ensure that any changes that happen are positive and that they are leading us to the ultimate goal of universal health care. But I think the key point here is the fact that we need a plan. There currently isn't a plan written out that would actually get us there, that looks at our current system, thinks about where we need to go, what type of laws need to be passed, maybe there's systemic changes or anything like that. So that's why CAPA took the lead in meeting with health policy experts here in California, individuals that really know the healthcare system, and wrote this plan. So it's on our website, caphysiciansalliance.org, if you're interested. And also, it's just really important to have champions. So individuals asking these types of questions and really pointing out that we can get there. We definitely can get there, and we really just need to be really cognizant of the fact that there is no plan, but anyone that sets a goal knows if you set a goal, you make a plan for it, and you work until you get there.
Anthony, you were shaking your head.
Yeah, I mean, I think you mentioned the Affordable Care Act and the fight about that, and I think you can see it at both glass half empty or glass half full. Like, just all the work that went in to pass that, and Health Access led a lot of the effort to try to pass the Affordable Care Act here in California, and we remember the very tough fight it took to get that passed, and how improbable it was, to get exactly 60 votes in the Senate, to get the 1 or 2 vote margin that Speaker Pelosi was able to get in the House to get that through, and then of course the 10-year psychodrama that this country's been in over the Affordable Care Act. But let's recognize the progress that we've made, that millions of people now have coverage that didn't have it before, have millions more of consumer protections. And when when people who campaigned against that law finally got into power and had the moment to undo it, there was such a backlash from the American public that at the end of the day, that effort stalled. That it was maybe one thumbs down away, but that effort stalled, and there was, I think, a changing in the expectation of the American public that people should not be denied for pre-existing conditions, and I think that's the basis of an American value that healthcare is a right. There is much more to do to fulfill that promise and that premise, but I think that we started to lay that not just in the passage of the Affordable Care Act, but in the fight to defend it. And so the question is, how do we build upon that? And we're starting to have that conversation now, both at the federal level with the presidential candidates, but also here in California. I know we're going to talk about that in a second, of what we can, the steps we can take even here in California to advance that goal and make progress. And I do believe that part of the progress is not just passing additional policies as elements of trying to get to this goal, not from just building the policies and the policy infrastructure, but also building the political momentum. Success breeds success. And I think that if we can more show people tangible progress, then more folks will come along for the next step and for the next step.
Dr. Batchlor.
So I just wanted to add that as conditions in our country change, the politics change as well. As healthcare prices continue to go up, even families and individuals that have commercial insurance, employer-based insurance that provides good coverage, are struggling with affordability. One of the ways that employers have maintained coverage is to increase deductibles and cost sharing, to the point that many families now are entering medical bankruptcy even with insurance coverage. We're also seeing a widening income gap, and a gap between the haves and the have-nots. More people are moving onto public insurance programs. A third of Californians are on Medicaid. Half of the babies that are born in our state are on Medicaid. So as these conditions change, we're seeing more public support for universal coverage and even for single payer. During the previous presidential election, people who said we should have single payer were told they were, crazy and unrealistic. And now during this election cycle, many of the Democratic candidates have a plan for how we get to single payer. So I think the politics are changing, and what's possible is now changing.
Thank you. Do we have another question in the front? Oh, okay, sorry.
Thanks. I have a question that gets to your talk talk about how market forces influence what we're able to do. We had a question that speaks a bit to the politics of the situation. I'm wondering what the thinking is or what's been done around, there's so many industries that are vested in the current system and the way that it works, and they stand to lose a lot if things change. And what have people been thinking about how those industries can be redirected, or also not offer a solution that isn't all a win-lose situation? Because I think that's how you maybe also help move things forward, and you help get more people on board when the lobbying that's so powerful maybe neutralized a little bit.
Maybe we could redirect them to work on climate change.
Well, I think that that's why you need a strategic plan. You need to really be strategic about how you are approaching this industry and remind them that they have a responsibility for the people that are buying into their product or whatever it is. That's why part of our roadmap is talking about responsible practices. And there's SEG standards that can also help with that. So there's different ways that you can really make sure that the industry is changing, because right now it doesn't have the patient's interest at heart, and it's very obvious, but no one is out there regulating them, reminding them of the fact that there is a patient on the other end of that phone call when you are denying the care. There is a patient that is struggling to pay those bills that you keep sending over and over again. And that they have a responsibility first and foremost. And doing that or addressing these problems should be in a strategic way.
One of the reasons that Medicare for America gets a lot of support is because it envisions an easier transition for the existing industry. So Medicare for America would allow Americans to participate in the Medicare program if they so choose, but would also allow employers to continue to provide commercial insurance, would allow insurance companies to continue to provide policies, would allow for Medicare Advantage plans, which are also run by insurance companies, but would begin to move the market more toward universal coverage and a unified payment system.
And continue spending billions of our tax money going right to those insurance companies.
Thank you.
Obscene.
Thank you. Yeah, go ahead.
Yeah, I mean, I think I appreciate the question, because I think if we're going to take single payer seriously or any solution seriously, we need to take the obstacles to that solution seriously as well. And there are real obstacles, whether it's voters' fear of change sometimes, whether it's procedural obstacles like the U.S. Senate or a state constitution, but I think, or ideological opposition, or just party politics that we see. A lot of the fight around the Affordable Care Act at the end of the day ended up whether you were Team Blue or Team Red, and given the way our politics has strung out. But in terms of the issue of industry opposition, it is very hard. I work in the state capitol, and it's very hard to advance a reform that takes on the entire industry at once. Right, doctors, hospitals, drug companies, insurers. We were able to pass consumer protections in Sacramento, but it's usually not when we have the entire industry opposed. It's usually when we can say, okay, how do we deal with the bad actors, with specific grievous problems in this industry or in that industry, and also make the case to other folks in the industry. Really. Do you want to defend what they're doing, and make that point? Because for example, with regard to rates, there are certain providers that are able to charge a lot of money, like again, as I said, 4, 5, 9 times Medicare rates, but the primary care physician is not one of those, right? So the primary care physician might actually King Drew might get an increase in their reimbursement rates under some of the reforms that we're talking about. And so how do you make that case, and not to say that you're going to get everybody to be happy, but how do you make the distinctions between either different industries or within the industries, because there is a positive case to make to most of the providers that, a lot of the providers don't love the system that they're in now either. And so how do you make that case and help make those distinctions? Because it's hard to take on the entire industry all at once.
So, yes, go ahead.
No, sorry, just a quick follow-up, because I think that is a great question. That $3.3 trillion, one out of every $6 in our economy, is somebody's income, whether it's a physician, an insurer, a drug company, a hospital. And so they do lobby and they fight and they resist. And so I think pragmatically, we probably won't get to a vast overhaul of Medicare for all, a single, let's say, payer or single insurer, until the fiscal solvency of Medicare and Medicaid is terrible, which is not that far off in the future. But I think what's more pragmatic is to more shift some of the risk of managing a population, which is what the Affordable Care Act did, is say, here are 5,000 or 10,000 people, manage that population, and we'll pay you per person, and you have to meet quality metrics. I think that incremental shifting the risk of high financial costs of a population onto a large group, a provider group, and say manage that population as efficiently as you can is probably what is more pragmatic in the short run.
So one of the issues that comes up when we talk about insuring more people or getting access to more coverage for more people is, do we have enough providers to address that? And do we have enough providers who are getting paid sufficiently to want to continue to do that? I wonder what your thoughts are on that, Dr. Batchlor.
So I can tell you the answer for the community that I serve is definitely not. And part of the reason that we don't is that we are a community that is low income. Most of our residents are either insured through Medicaid or uninsured. It simply doesn't pay enough to attract the providers in the community that we need. That's why our emergency department is caring for over 100,000 visits a year, because there simply aren't enough providers in the community. So what we'd like to see is a plan that both provides universal coverage and introduces more equity into the system so that resources are distributed a little more fairly and people in our community can access the primary care, the prevention, and the disease management that will keep them out of the hospital and ultimately lower our costs.
Angelica, what does CAPA believe would be a way to handle some of that physician shortages if more people are getting care?
I definitely think that we need a multifaceted approach. So it can't just be investing money into primary care. We need to make sure that the physicians in these communities, if we're talking about equity, that they look like the community members there, that they understand what it's like to live in these communities, and that they have that cultural sensitivity as well. So I think that we need to think about grants to support primary care, but also look at medical education. So we have to support students of color, low-income students, students that belong to underserved communities, and support them through college and then also into medical school. We are reliant right now on loan forgiveness, but if you think about it, I'm sure a lot of you in the audience know how much having loans weighs on your psychology. The ability to go into work and know that you have to pay back those loans. So why aren't we thinking outside the box? Why are we just relying on loan forgiveness and making that interest just get bigger and bigger over the years? So we have to really think about approaching this topic of having enough physicians that look like the population of California in these communities from multiple approaches at the same time. I think that one of the drawbacks from everything that has been tried so far is that it's usually investing a lot of money just in one portion. And instead, we really do need to think about preparing the next generation of healthcare leaders, making sure that we are anticipating the needs of the California population. Our current system isn't set up to meet the population of California in 2019. It's actually set up to meet the population of 1996. I remember hearing this in one of the conferences. Why are we always playing catch up? It doesn't make any sense. We really do need to anticipate the needs of the future population of California.
Yeah.
One thing I must say is that the data suggests that American physicians are paid 25 to 35% more than their comparison physicians in other countries. But the number of physicians per 1,000 population in the U.S. is significantly lower than in our comparison countries. So if you think about what we spend on doctor services, it's not out of line with our comparison countries. So when you talk about the supply of physicians, we're already at the lower end, Michelle, relative to European countries. So I think one option is physicians are expensive. We can be smarter about it. We can have more pharmacists and nurses treating basic primary care issues, right? Runny noses, the minute clinics, and the success of them in these malls are partly meeting an unmet need. And the vast majority of the cases they're handling can quite easily be handled by nurse practitioners or someone below a physician level. So yes, we probably need, if we're going to put more emphasis on primary care, we need more physicians, but we could probably do it smarter and more efficiently.
Sure, Anthony.
Yeah, and beyond the scope of practice issues that the professor was talking about, I mean, there was a major commission that actually looked at healthcare workforce that was released earlier this year. I mean, a major commission with the UC president and a number of other luminaries coming out with these issues, and they came up with many recommendations, some of which have been mentioned here, some of which are in place now, things like loan repayment. In the new budget that was just passed in the last week, there is money from the tobacco tax that we helped campaign for a couple of years ago that goes to loan repayments for doctors who are willing to commit to serving at least 30% Medi-Cal patients, for example, or to work in certain areas, for example. Because one of the issues is that I think that there's a question about whether it's a shortage. There's clearly a maldistribution of doctors. There's no shortage of doctors in Beverly Hills. There is in
South LA.
There is in South LA. There is in the Central Valley. So I think that there's something to be done about distribution. There's something to be done about training and having a pipeline of new and frankly diverse population. And there's also about how do you actually even provide the care? Is it about doctors, or is it about the whole range of health professionals? And what can we do on the upstream before we even get to the intervention in a doctor's office? So it's a range of things. And again, a more coordinated universal system would be a better way to manage and handle and plan and invest in the system we want, rather than letting the market dictate. And the market dictates that, oh, there's few specialists, that means specialists get paid more. And so if you're training to become a doctor, it seems very lucrative to go into those specialties rather than primary care, even though societally we actually need more primary care doctors.
Right. So you brought up, Angelica, the idea that we need more culturally appropriate care. We are also living at a time where there are major disparities, not only in income, but also in race, in the kind of outcomes that people are getting. My colleague, Priska Neely, you've probably heard, and if you haven't, you should look it up on LAist.com or go to KPCC and look at the reporting that she's done on the disparities of the number of Black babies that are dying and not making it past their first year. Latino children are not that far behind them, and Black mothers and Latina mothers are dying very quickly in childbirth in ways that they shouldn't be. And that's just one of the many other disparities that we see in healthcare system. What are some of the things that we can do, even as we expand access, that we're sure that the quality is equitable? I'd like to start with you, Dr. Batchlor.
Well, I think one of the things we could do is measure quality and report on quality by ethnic group, by income levels, so that we have a more transparent system. We're able to see what's happening, and we're able to hold providers accountable for their outcomes. Physicians tend to be very competitive, and when you measure them and you put it up on the wall, they figure out how to do it better. So part of it is making our workforce more diverse and having better alignment between providers and patients. That's something that we've been able to do in my health system. We've done a great job of recruiting very talented physicians who are African American, who are Latino, and it makes a huge difference to patients. Even when I was in medical school, I realized that patients who didn't speak the same language as their doctors weren't getting the same quality care. So I think it's a combination of things, but I think part of it is shining a light on what's happening and holding people accountable for better results.
What can we do in policy for that?
Well, I mean, I think there's a lot that we can do. First of all, is just have the focus on equity. It's not just cost, it's not just quality, it's about equity. There's things we can, that if we don't have an equity lens on these things, there's some reforms that happen that could have a disproportionate impact on certain communities if we don't have the data to really monitor what's going on in certain communities that have special needs, whether it is racial categories, whether it's the LGBTQ community, whether it's income or other issues. In terms of some specific bills, going to Dr. Batchlor's point about the data, one of the bills that we're sponsoring this year, AB 929 by Assemblymember Luz Rivas, would actually require that the plans in covered California have to not just report, which they and detail their quality metrics and their equity metrics about how they're doing in certain health outcomes, but that information be public and published to you as the consumer when you're selecting your plans on Covered California. And that's we think an important thing so that you can do both price comparisons but also quality comparisons plan by plan. And so to have that plan-specific information, I think that's an important thing. I think another piece is not just to deal with the fact that there are these disparities, but also recognize that some of the disparities are because of people's circumstances and the social determinants of health, but they're also due to the societal issues we have, including ones of bias. And so, for example, you mentioned the very significant issues of Black infant mortality. There is a bill by Senator Holly Mitchell, SB 424, that would require implicit bias training, especially for the issue, to deal with the issue of Black infant mortality. And I think that that's a step to acknowledge that there are things that we can do that are universal to improve the system for everybody, but there's some specific remedies that we need to address specific problems in specific communities.
So, yes, go ahead.
Just really quickly, I think that we have to be a little bit careful about shifting this to the providers. We are seeing large numbers of burnout among physicians and other providers. And the reason why they are feeling burnt out is because of the need to see this many patients within their day. So this is, once again, talking about the system being about profit, being about seeing as many patients as possible so that the insurance companies can turn around and say that they've made large amount of money for their shareholders. Although I do think that we have to look at race, we have to look at bias, we have to look at the social determinants of health, I think that we really have to be careful to shift this over to the physicians because there's a high number of burnout, suicide rates among physicians and other health professionals.
So as we talk about inequities in healthcare, one of the things that has changed will change very shortly in California is that Medi-Cal is now going to be shortly covering people up to age 26, regardless of their immigration status. I wonder if you believe, Dr. Batchlor, that that's going to make an impact on your patients. Is it going to expand the number of patients that you'll be seeing?
I do think that it will make an impact on patients. It's a good thing. It's progress for people to have some coverage rather than not having coverage. That's hugely important. But I don't want to lose sight of the fact that Medicaid is still underfunded, and people who are on Medicaid still struggle to access quality care. But it is definitely the right thing to do, a movement in the right direction, and it will make a difference in accessing health care.
Dr. Joyce?
No, and you can just make the public health argument, right? Not only is it ethical and the right thing to do, but it benefits everybody when you don't have an indigent population that's being untreated.
Right. Okay, so I want to leave a little bit of time to have some questions, but I'd like you to tell me, having heard each other speak tonight, as we begin to wrap up, was there anything that you heard tonight that was new or points to a different path maybe than what you originally came in with thinking would be the best path for healthcare moving forward? I'll start with you, Anthony.
I mean, first I do want to just reiterate the exciting progress that we have made in California with regard to expanding Medi-Cal to all income eligible young adults, regardless of immigration status. That is the first time in any state that we are expanding Medi-Cal to undocumented folks that are not children or pregnant women to another adult population. And that's not the only thing we did in the budget. We also took steps to provide greater affordability assistance in covered California with significant new help, especially for those over the 4 times the poverty level cliff where the Affordable Care Act runs out. There was other expansions of Medi-Cal to seniors and improvements like restoring some key benefits that were cut 10 years ago, like audiology and speech therapy. So, I want to acknowledge the progress that we've made in California to take steps toward it, but there's so much more to do. And I think what I heard here was the range of those steps. And I think the thing that sometimes this gets framed as a debate as, is it, go for a full solution or just build on the Affordable Care Act? And I think the right solution is always both, right? That, people can't wait for the help that they need now. Anything we can do now would be great, recognizing that there is but we also can't lose sight of that longer vision that will take some time, that will have some transition efforts, both because of the politics of it, but also because of the policy to get to that vision. And we need to have both. And I think what we heard here was, I think, a fuller explanation that I think I've heard in a lot of the national conversation about how we actually can marry these two complementary efforts together.
Dr. Batchlor.
So one of the things that I heard tonight that's heartening is I heard pretty complete agreement among this panel that we ought to have universal coverage in this country, that it's time for that. I also heard a lot of pragmatism around the various proposals and issues that need to be addressed. And I think that if we continue to work together, address the challenges, that we have a good chance of getting where we all want to go. So I'm pretty optimistic.
Dr. Joyce.
Same. I thought you'd have a ringer in here that would stir the pot a little bit, but I think we all basically are of the same mind, where we spend way too much on health care. We're a very wealthy country. We should not have 28 million uninsured people and another 20 million underinsured people. So I think we're all in agreement, and you guys who are here, I assume, basically are here for the same reason. What I think it get mentioned a little bit, and I think we overlook, is the link between health insurance and health is not that strong, or as strong as you think. While everyone should be insured, the Whitehall experiments in Britain, the Oregon Health Study, the Rand Health Insurance Experiment all found when you gave people insurance or more generous insurance, it had modest but fairly small effects on health over intermediate time frames. So we shouldn't lose track of, we do want to improve health, right? Health insurance is important, but the ultimate goal is how do we improve population health? And that gets lost in all of these discussions.
Angelica.
So I agree with the other panelists. I think that it's great that we agree on the fact that we do need universal health care. I think that what was missing was really, how do we get there? The actual plan. So I've been saying the same thing, that we need a plan written down for that and a plan forward. I am optimistic myself. I think that it's great to see a lot of people here that support the notion, I'm assuming, of universal health care. And I'm optimistic because we have a student branch, CAPSA, and these students will be the future leaders of the healthcare system. They are pre-med, they're pre-nursing, any health professional. And along with the polling that took place this past week at the American Medical Association to support single payer, or to take away their official opposition to single payer, it lost by just a tiny margin. It was 47 in support of taking away that opposition to 53%. But I think that the key point is that the 47% was led mostly by medical students. So this means that the future leaders of healthcare want single payer. They want universal healthcare. They want Medicare for all. So I think that if we can present a plan to move forward, that there is support. And as soon as these students have the opportunity to take action, which is now, they can go ahead and speak to their legislators, be involved in these conversations, like showing up. I see a lot of young faces out there. And I think that we just need a plan to move forward.
Okay, I'd like to take a moment to ask a few more questions. We have our mics out there. There's a couple right here in the front. Oh, okay. Right here. Okay, I can't see the lights.
I got it. Hi, Michelle. Couple of comments. Burnout. I'm a family physician, have been for a long time. Burnout is not because we're seeing too many patients. Burnout is because we are doing too much clerical work and reporting too much. And we're reporting on quality issues that we didn't determine as doctors. They're quality issues that the bureaucrats decided would be a good thing to count. So we count a lot. In terms of the managed care system, which I am part of at times, it really outrages me when I go downtown and see a tall building with the managed care insurance company's name at the top. When I go out to the valley and see tall buildings with the insurance company's name on the top. When I go down to Long Beach and see managed care companies with their names on the top. I don't have a building with my name on the top. I'm just a doctor trying to take care of patients. But I do know that the overhead for insurance companies is about 30%, and the overhead for Medicare is about 3%. And somebody said, well, Medicare negotiates its fees. No, Medicare doesn't negotiate its fees. They set their fees, and that's what we take. The insurance companies set their fees and reduce them on a daily basis. So as a primary care physician, I'm getting paid about, in real dollars, the same amount of money I did 20 years ago. So there's something wrong with the system. It's been chopped up. It's been turned into a medical industrial complex. And patients are suffering because of this. When we asked the question, or when Obama asked the question, do you like your medical care? Wrong question. It's, do you like your medical insurance? And if you answer that question, most people don't have any idea what the answer is. They
Thank
may
you.
like their doctor, though.
Yeah, thank you, doctor. Did you have a comment, Dr. Joyce?
Well, you said a lot of good things I agree with. One thing, there is a bit of a misnomer of Medicare being much, I think a single payer, obviously we have a very fragmented system and there are inefficiencies in it. But I think Medicare sometimes gets put up as this beacon of efficiency. Well, first of all, their administrative costs tend to be lower because it's a proportion of what the spend is. And it's basically covering seniors who consume a lot of health care, so you have a small administrative cost over a very big denominator. So it's a little misleading in that sense. In addition, there's a lot of fraud and inappropriate use within Medicare where there really isn't a financial incentive to root that out. And so I think we would clearly save some money administratively in simplifying our administrative structure for sure, but it's not of the magnitude that you and others have discussed.
Anthony.
I would I appreciated your point about the, do people like their health plan? And I would postulate, because, in dealing with insurance companies at the State House, at the Department of Managed Health Care, insurers will typically say, well, we have a 70% satisfaction rate, an 80% satisfaction rate, and part of it, as I look, I say, well, how many of those people actually use care in a given year? Like, because I think when most people who you ask, do you like your health plan, have not really used that health plan in the last year because they're healthy, right? That they've gone to the doctor, they've gone to the doctor once or twice, they've had a good experience, and then that's fine. If you really want to find out if a health plan is good or not, ask the cancer patients, ask the people who are dealing with HIV, ask somebody who has who's really using it in a real way, rather than just the people who are happy to have the card in their pocket. And what they're liking is a financial security that comes with health coverage. Because let me be clear, people want and need health coverage. I agree with the professor that actually health coverage doesn't have a big impact on your health because it's really about after you get sick, right? You know, health coverage, you know, hopefully gives you the primary preventative care to help you get healthy, but it's really about the financial security once you get sick. It really is protecting you so you're not one emergency away from financial ruin. And so I think that as we try to, so number one, I do think that there is an opportunity to take a look and really evaluate health plans based on the people who actually use it, you know, which is that 20% in any given year, not the 80%. But number two, I do think that as we reform, we should acknowledge how much people really value that financial security. And there is really good evidence that even the Affordable Care Act expansions have made a big impact on bankruptcies, on foreclosures, and also on people's anxiety about their financial situation. And so what we need to provide and expand on is how do we provide that financial security to people. I work in healthcare, but I think I'm much more in the business of providing, giving people economic security in a broader way.
We had a question over here.
Okay. Okay, so I'm old school, so I just want to go. You see, I think our experts talk more about, like, you know, the single pay, we all know it can work, and it's easy. If you go to, like, 5th grade and then just give them a scenario, like, hey, we have, like, 350 million people right now. Some people have, like, good health care, others don't have it. You see, so how can we bring a plan that everybody can have a health care? I bet, like, 5-year-old or 6, I mean, it won't be, but it can try to draw a plan like everybody can have it. You see, when you read the news, like, they made, like, trillions of dollars, you see, and then they've created the idea that the single pay is not gonna work. You see what I'm saying? And then we Americans, like, we believe in statistics and experts and all that stuff. You see what I'm saying? What I'm saying, when they put that intention in our mindsets, you see what I'm saying? We don't, like, it's like we don't know where to go because, like, from Harvard, they say, like, if it's single pay, the economy is gonna be boom. You see what I'm saying? So if we educate people like that, how can we also improve the whole system? You see, but we all know that we can make it work. So even if we can't make it work, why don't you, our leaders or, like, our experts, sit down and then bring a plan that, you see what I'm saying? But most people think, like, maybe it's a cost insurance company, but if we actually sit down and then do the single pay, we can turn some things around. Now, flood insurance, people don't even buy it because it's expensive. You see, but it's insurance company, they are right to sell those insurance to people who live in, like, fraud areas and stuff. You see what I'm saying? But they all know that healthcare it's like we treat healthcare like a fashion. You see what I'm saying? So it's like, if you have the money, you can get to whatever system you need. But that is, like, everybody's needs. Like, everybody needs to survive in this world. So I think that we should actually plan on making that single pay to work for everybody. If it's going to create a problem, then we should actually take education, healthcare in a single sector so that, like, we can actually have focus on that aspect without no partisan or anything. In that case, we can actually have more focus on that. But with, like, business, everybody's trying to, like, make billions of dollars. It's hard to kind of track, you see. And then, I mean, I don't care if you make trillions of dollars, but if everybody gets the same care, yes, you see, then that's what you've made your job. But if you make all this money and then you don't, but how can you know?
So,
that's what
So what I'm hearing you say is that you believe that healthcare should be a right. And
exactly.
So do you have a question for the panel?
My question is, like, okay, so the question is, like, what I'm trying to say is, like, we talked about our hour and a half, and most of we all agreed on single pay. Yeah, but some people also think, like, single pay will not work. You see what I'm saying? Because they have their statistics based on whatever research they've done. You see what I'm saying? But what I'm trying to say is, like, we shouldn't advertise because I heard a whole CEO on the television saying, oh, we can work and work and work, single pay is not gonna work. You see what I'm saying? He's a role model. And if my role model told me that, the moment he said that, I'll forget about that. You see what I'm saying? And then think of other else. But what I'm trying to say is, like, you can make your millions, but still people are dying. You see what I'm saying? You're saying African Americans, like, even they can't even get through 1 year.
Right.
You see, but then we are all human beings. We are all the same people. The same earth. This earth is not for anybody. It's for all of us, how to protect it. So how is it that somebody who is just sitting down somewhere, you just brought a person to the world, he doesn't even know what is going on. You see what I'm saying? And then he has to also suffer from someone's issue. You see, it's the thing that we can talk about it over and over again. And the issue is that when we talk about this, we are also overshadowing some other issues that is important, like transportation, like maybe, you see what I'm saying? So what I'm trying to say, we should actually sit down and then have a good plan that it can alleviate this healthcare issue so that we can do away with it. Because we've come a long way.
Okay.
You see what I'm saying?
Thank you. I appreciate it.
I mean, one of the things that folks should be aware about is that, again, I think this here in California, I mean, clearly the presidential candidates on the Democratic side are having some of this discussion right now about what is the steps, what are the path to get there. I think at the state level, folks should recognize that both this legislature and this governor have, although in slightly different ways, proposed having a commission, a council to really plan out what does moving California to such a universal system look like, including a Medicare for all type system. What does that look like to cost it out, to flesh that out over the next year or so? And so that's something that is going to be resolved in the final budget that's being passed in the next couple of weeks. And so we're going to have that conversation here in California, recognizing that there may be obstacles, including a federal government that is hostile to healthcare in general and California in specific. So so what are those steps that we can take in the meantime, like some of the things that we talked about, but how do we plan for that future so that we can move forward to that? Winston Churchill did have a comment, though, that Americans always do the right thing after they've done everything else. So.
And just to follow up on that, while there's probably near unanimous support for some sort of universal coverage in this room, the Republicans are already messaging this as socialized medicine, right? It's socialism, and Ronald Reagan called Medicare socialism back then. So there are segments of the population that are clearly not in support of this right now. So the transition is not as simple as it seems.
But I think that you really brought up the fact that we do need to approach this from various different sectors. So one piece is public education. Like you were saying, if you hear your role model telling you that single payer isn't going to work, you as a young adult that is learning about the healthcare system that seems so daunting, of course you're going to take the advice of your role model. So what's really missing is public education. So CAPA has created some videos that are, approachable. We can't have, right, today we were speaking in some policy jargon, right? There's a lot of people out there that don't know anything about the healthcare system. I didn't know about the healthcare system growing up because I was just trying to survive. And these are the people that need it the most, the people on Medi-Cal, the people from underserved communities, the people that are suffering because of the social determinants of health. But using the word social determinants of health already takes a lot of these people out of the conversation. And that's what a lot of people don't realize, that you have to make sure that the messaging is for the audience that you want. And the fact that we are using words like single payer, universal healthcare, Medicare for all interchangeably is also causing confusion, like the KFF polls have shown. So simple videos like the ones that CAPA has created would be really helpful, but I think that also making sure that we're approaching this problem or this goal of reaching universal healthcare and single payer from getting support from the public, getting support from people that are legislators, getting support from health policy experts, getting support from young adults, and actually valuing their input as the future leaders. So I think that we just need to really make sure that we encompass many factors into this movement.
I would say more forums like this, where people are being educated about the issues, where we're talking about the challenges, and where people are getting more engaged and really learning about the pros and cons of the different approaches, so that we have an educated public that isn't going to be fearful of the unknown.
We have time for just one more question.
So on the state level, there have been many organizations that have been keeping universal health care such as the Nurse Association and then Health Access, as well as CAPA, has been leading a lot of the incremental change, which we've highlighted today, such as individual mandate and health for all young adults. And it's been amazing to see all of that change. So I wanted to ask what you all see as being a priority for next year. What do you see the governor prioritizing, actually taking a real approach on? What does your organization support for next year? And what is something that is realistic that we can support?
What 70% of Americans support Medicare for all, single payer.
Thank you.
Yep.
We're going to continue the conversation afterwards, so if we can hold our comments. Go ahead.
So, I mean, I think I want to highlight a couple of things that are happening. Again, you know, in this state budget, we have taken some important steps to increase affordability assistance so that hundreds of thousands more Californians don't have to spend more than the percentage of their income to get coverage. That to expand Medicaid to more people who currently fall through the cracks or are excluded from coverage. And I think we would like to have Governor Newsom continue on that steps to take those steps down. Again, not as a replacement for the broader goal of a fully universal healthcare system, but as a complementary effort to take those steps toward. We can, without federal approval, before we even get to the question of you know, will we have a new president and a new Congress that we could actually deal and have that conversation with, California can take steps now to cut the uninsured rate in half again. We went from 20% uninsured down to 10%, from 7 million uninsured down to 3 million. We can cut it in half again to the 5% that most industrialized countries are at. If we just here in California, here in California.
Can we please let the panel speak? Thank you.
I also want to say that there are things that we can do, not just next year, but in the next couple of weeks to confront the industry with regard to ways that they are right now taking advantage of consumers. I'll just point to two bills in the limited time we have. One is on prescription drug companies. There's a practice where they actually pay their generic competitors not to compete with them so they can continue to charge inflated rates. It's called pay for delay. And there's a bill, AB 824 by Assemblymember Jim Wood to enforce to prevent this practice, which now we now spend $3 billion a year as Americans because of inflated prices because of this practice. It's something that Attorney General Becerra is working on. We're working with him, and that bill will be up in committee votes in the next couple of weeks. The other bill is on surprise medical billing, AB 1611 by Assemblymember David Chu. And this is the question where if you go to an emergency room and it happens to be out of network, you get a bill of thousands, if not tens of thousands of dollars. And it's basically because the hospital has a monopoly of you at that moment because you don't get to choose what emergency room you go to when you're on the gurney of an ambulance. We want to make sure that you do not get billed more than whatever your cost sharing is in your insurance plan, and that the hospital doesn't get to charge whatever they want. That there is a fair reimbursement, but it's not one that inflates the cost of the system. And so that bill is probably the biggest fight in the legislature right now on the healthcare industry, and there will be a vote by your senator, including many from Los Angeles in the state legislature. That's AB 1611. So those are some actionable items that you can take to, again, provide real help to real people in the next couple of weeks.
Elaine, please. Elaine, you had some thoughts for the move,
Well,
the
I
passage
think some
forward.
of the other things we could do in this state is improve the Medicaid program. That's a program that's run by the state. It's a partnership between the state and the federal government. We want to protect the gains that we've made under the Affordable Care Act. So we don't want to go backwards, but we do want to make that program stronger and improve access to the patients who are already insured through that program. Another thing we can do at the state level is improve funding for educating healthcare professionals and starting to correct some of the maldistribution that we talked about earlier. So I think those are some of the incremental things that we can do, immediately.
Dr. Joyce?
Just say, and I'm, You all know more about state politics than I do. Unfortunately, I think the states have had to become more innovative and thoughtful because of the vacuum in Washington. But when we do talk about broader healthcare issues and Medicare for all, or that type of universal, it really should be federally sponsored and supported. But states are going to have to do as best they can in this vacuum.
I think we can do a lot at the state level. As many of you might know, that in Canada, their universal healthcare system started at their province level, right? And they're, well, what they call states. So why can't California, that has one of the largest economies in the world, take action into their hands? So I think that it's important to understand and remember that California can definitely do a lot. We hold a lot of power, and we can show the nation how to move forward. Our ask is that our state legislature and our governor come up with a strategic, approachable, and realistic plan to get us there. Something that isn't disruptive to our system, that gets buy-in from the public. And, you know, we've talked a lot about consumers who might be scared about change. That's just human nature. Something that is measurable. We are measuring how we are getting to a universal healthcare and unified publicly financed system. Something that clearly lays out that we want a unified publicly financed system. And I just really think that there is a lot that we can do. And something that all of you can do is go to our website, caphysiciansalliance.org. We have our roadmap up there. It's 20 pages. You can sign our petition to really get support for it and to move our state to universal health care.
I would like to thank our panelists at this time. Thank you very much, Angelica Ramirez, Dr. Geoffrey Joyce, Dr. Elaine Batchlor, and Anthony Wright. And I'd like to thank all of you, our audience, for being here today and participating and asking great questions. We'll be having a reception afterwards to continue the conversation. So thank you very much. I'm Michelle Faust Raghavan, and this is a KPCC in-person production.